All right, it is noon, so we'll go ahead and pass it off to Evelyn Nelson to get us started today.
Welcome, everyone. We're so glad to have you at today's All Under One Roof Echo. We know what a busy time of year it is, and we're really appreciative to have you join our session today. Really excited about the content. Just as a reminder, our Echo today is supported through our Telehealth Rocks funding. It's federal funding from both HRSA and SAMHSA to help advance behavioral health, especially in our rural schools. I just have a few housecleaning things to remind everybody. Your microphones have been muted, but we really do want to hear what's on your mind. So please do unmute or type your questions into the chat. We'd love to hear from you. When possible, we appreciate you keeping your cameras on so we can create that community of learning. But we also understand you may be joining us eating your lunch, and that's a-okay as well. Make sure you do type your first and last name into the Zoom screen. That helps us make sure we get your certificates of attendance, and those will be emailed out after the last session.
Great. We'll go ahead and each introduce ourselves. My name is Dana Becula. I'm a psychologist at Children's Mercy, but I'll let all of our presenters each speak up and introduce themselves.
Hi, I'm Emily Goodwin. I'm a pediatrician at Children's Mercy in the Beacon program for children with medical complexity and their siblings.
I'm Ryan Smith. I'm a general pediatrician at KU and medical director for Pillars Medical Complexity Clinic.
And I'm Nicole Crump. I'm an administrative assistant for the Kansas LEND program at KU Med, and also the parent to a little girl with a rare disease and medical complexities.
Great. Thank you all. Next slide. So today we'll go through some introduction and disclosures, and then we'll have a didactic presentation followed by a case discussion. Next slide. We do not have any disclosures to discuss today. Next slide. And after the session, just like all of these, the slides and recordings will be sent to you, as well as certificates of attendance. We do have a survey today where we're asking you questions about your experiences with this ECHO program and your thoughts. We really value your opinion and feedback. It really helps us guide directions for where we go next and what ECHOs we offer. So please, please, please fill out the survey after today, and it will be sent around during the session today so that you have it before you leave. Next slide. And with that, I'm going to pass it over to Dr. Emily Goodwin, who's going to start our discussion today talking about having challenging conversations and engaging in communication with caregivers of children with medical complexity.
Thank you so much, Dana and Nicole, for having us today. So I want to kind of pose this question to the group, so kind of think to yourself or put it in the chat. But what makes certain conversations or communication so-called challenging? And if you, Christy, if you press the space bar or click, I'm going to refer to a book called Crucial Conversations. So for me, when I think about challenging conversations in a medical setting, it might be delivering difficult news or a diagnosis, or even just talking about something that maybe wasn't expected or was different than expected. And in this book, they describe these as crucial conversations when there's three elements. There's high stakes, there's strong emotions, and then potentially opposing opinions. Next slide. So in medicine, when we're facing decisions that may be crucial or challenging, we often use what's called shared decision making. And so I just wanted to introduce that concept if it's not familiar to you. Shared decision making is an interactive, collaborative process in which patients, which includes family and children, based on their developmental and cognitive level, they really should be included in the conversations, and physicians, as well as other professionals that are involved, and simultaneously participating in all phases of the decision-making process, and then together arriving at a treatment plan to be implemented. And so shared decision-making is really a best practice that's recommended whenever there is more than one medically reasonable option that's consistent with the standard of care. And key features include having more than one party, and information in all directions, right? So it's not just a one-way conversation, like this is the plan. It's all parties are aware of the options, what they are, and then bring their own knowledge and value-related priorities equally into the decision-making process. So I want you to kind of think about that. There's a lot of different frameworks, and I have two in the references and resources that talk about this in more depth, but I want you to kind of think about this as we talk about different cases, or you think about crucial conversations that may occur. So next slide. So I had a recent clinical experience that a parent told me their child received a diagnosis of cerebral palsy and malnutrition. And they only found out when they saw the note after the visit. So I feel a lot of emotion just reading that, saying that, and I can't imagine what that felt like. Both of these were in different clinical experiences, but it brings to light a lot of components about communication, right? So with the age of electronic medical records and patient portals, records have always been available to patients and families, but they're much more readily available and immediately accessible often. And so, used to have to go through medical records department and get stacks of paper, and a lot of people just didn't do it. And so the medical chart serves as many purposes to communicate what occurred in a visit, but often it includes in the written note a lot of medical jargon. So it might not be the words or terms that we always actually say in a visit when talking with somebody. And there's also billing and coding and legal and all sorts of other elements that have to be communicated to insurance companies and payers, as well as other healthcare professionals that might be involved in taking care of that person. And so the words that we use for clear communication might be different than what's put in a diagnosis, but the diagnosis of cerebral palsy is one that, for me, if I was giving it or receiving it, I think I'd want that to be an in-person conversation. Malnutrition was actually an encounter with me, so it was a very humbling experience, and I was so grateful to the parent for bringing it up. That during the visit, we did talk about the diagnosis, but not using that word. We talked about healthy weight and growth expectations. And so it was a very humbling experience. And I think one that's really, really important to think about how important it is, the words that we use and the elements of communication. And we thought this was also maybe a moment. Nicole, I don't know if you want to add anything just as a lived experience moment.
Sure, I can briefly share that I've had experiences kind of similar to this, where I maybe knew in some way that some of these things were going on with my child, but then to see them written was a completely different experience. And words do carry a lot of weight, and the way that they're communicated really sticks with families, sometimes for a lifetime. So just to be always so conscious of the way you're presenting information, I think even preparing a family to see that they will see a particular word written in a chart and say, we're talking about it this way today. This is the reality of the situation. How I need to write about it for clinical purposes is this, and that's what you're going to see. It doesn't change anything about your child or their diagnosis or the plan that we just came up with. I just wanted you to kind of know that it might look a little different. Yeah.
That's super helpful. Next slide. So when we think about communication, again, the words that we say really matter, right? And communication has many components. So it's what we say, the content or the topic, the words that we say, just as we were discussing, but also how we say it. What is the tone of voice? What are the nonverbal communication, eye contact, body language? What is that portraying? The method that we use to deliver the communication, is it in person? Is it written? Is it virtually? Social media, some combination. So Dr. Smith was actually going to talk a little bit more about the method, and maybe in the prior example I shared, written might not have been the right form, and everyone might have different preferences. And then communication's not just delivering messages, it's receiving them too. So listening is a really important component, and actively listening, not just thinking about what will I say next, but really listening to what that other person is communicating to you. And then another book I'm reading, Humble Inquiry. I really liked this. It's the fine art of asking and not telling, to draw someone out and ask questions to which you do not already know the answer. And you're building a relationship based on curiosity and trust in the other person. And really, to use shared decision making, you really have to get to know the other person and their values and respect them. And finally, responding. How do you respond to information, and how do you interpret the other people you're communicating with, the way that they respond? And so our goal, of course, is always to respond supportively. Next slide. So recalling back to our previous sessions about ways to respond supportively, we want to make sure we recognize trauma responses, that caregivers' fears and worries come from a real place. If I'm having what I would consider a crucial or challenging conversation, or one that could be, I like to sit down, get eye level or below the person I'm talking with. I'm going to really pay attention to all those components of communication, trying to keep tone calm and kind, and empowering caregivers or really whoever you're communicating with, and creating and holding that space that feels safe, and asking permission and giving choices wherever you can. So I'm going to hand it off to Dr. Smith, who's going to get into more details of methods of communications and ways that this may play out in a clinical scenario. I don't know if Dana or Nicole, you have anything else to add?
More just to reiterate that these experiences also really stick, and families will remember the exact way that you made them feel in a given scenario or circumstance. And so I love this idea that you even are mindful of things like eye level, and even like the brightness of a room or the smells, everything. All of that is so impactful, and it's such an overwhelming sensory experience because of all of those things. So just to be kind of mindful of that. And even an example I can share is a resident from the PICU calling me completely outside of his normal time that he was with my daughter, just to validate kind of what I was going through, and say, I've learned a lot from your daughter. This has been a really humbling experience for me. Thank you for sharing your child with us. Well, I'm here. What else can I do? And it was like, whoa, even setting up that environment and that tone in a phone call will be something that I remember and cherish forever.
Thank you. Next slide.
Thanks. And again, I think I share Dr. Goodwin's humble humility in being asked to kind of talk about communication, engagement with caregivers and children with medical complexity. And I just think about, I'm about 10 years into practice, kind of edging on the later stages of early career, and throughout my medical training and definitely my first years of practice, I think I stressed and focused and obsessed over those times that I made errors in medical decision making, providing the right treatment, making the right diagnosis. And I have to be honest, over the last few years, I kind of look back on experiences I've had in clinical medicine, and my failings, my missteps in communication are things that I worry about a lot more. Because the fact of the matter is, we have we are lucky enough as providers to provide care to children with medical complexity and engage parents and other caregivers. And again, like their center, and we are just in this kind of outer scope to support them as best as we can. So in communication, it can be somewhat overwhelming. I know within our health system, just within clinical communication within providers, we have, I think, 12 different systems. We were trying to work to change that. But that's just within a particular institution. And fundamentally, access to various forms of education, communication varies greatly across organizations. It's so variable. For example, at Children's Mercy and KU, our practices are entirely different as to what our preferred methods, how we go about communication, who responds, and what tiered level of responses there are. These methods of communication are dictated by a lot of different things. Sometimes it's policy, sometimes it's logistical considerations. I'll give you an example. My nurse, Mike, who does just incredible service to our families of children with medical complexity, has given out his telephone number to patients to communicate. And this is actually completely prohibited for nurses within our health system for some security and kind of work labor considerations. And again, like I think that when methods of communication aren't immediately available, there may be the thought that they're not available because people don't want to spend the time, don't want to communicate, or creating barriers. And sometimes that's not the case. Sometimes it really is policy, and there's decisions that go way above my pay grade that can provide some dictate as far as what are those tools that we can use for communicating. We have a lot of these on the list here. But one thing I want to highlight is a lot of the tools that are designed for communication are really designed for caregiver and patient to communicate with the clinical team at a particular institution. And this is the thing that's kind of tricky is as we have school team members, as we have clinical team members at other institutions, as we have case managers from Medicaid, from other health insurance companies. Communicating together is one of those things that's really, really difficult. And so I think it can be helpful just to have a list of all team members. And I will say that that's one of those things that represents a significant amount of time for me in clinical practice, but trying at least once a year, if not more, to list out not just the primary care provider, not just the therapists, the social workers, the specialty providers that a family is seeing, but school counselors, teachers, everyone who a caregiver and patient think is kind of critical to their care. And so again, like I listed some of the clinical communication tools that we use, but I think another thing that's really important to understand is the value in communication with your peers. And I know over the last 10 to 15 years, there's been a lot developed for caregivers and children and young adults with medical complexity to connect with other families, other individuals that are experiencing kind of similar type issues, whether it's CareBridge, whether it's social media, like things like Facebook groups. And I think it's important for caregivers and children with complexity to engage in that those efforts. But I think it's important for clinicians, for therapists, of course, in HIPAA compliant, privacy respectful manner. But I think it's important for us to kind of share and communicate our experiences and navigate all these challenges that we have. Next slide, please. this again just kind of lists some of the different team members that it is by no means exhaustive, but some of those that are involved in care of our families. I think one of those things that ends up causing problems with communication is that distinct vocabularies and lived experiences that different staff roles have. And we kind of saw it in Dr. Goodwin's case when we talked, and I think there's been some interesting comments in the chat, specifically Nicole talked about certain words and diagnoses and clinical descriptions really being loaded with a lot of weight. But those are how we speak, what verbiage that we use to speak really has an impactful way in the effectiveness of communication. And it's interesting because I think like as medical complexity grows, as the needs, the challenges that emerge within communication, it is easy for team members to feel nervous and skittish about reaching out to other team members, especially those within a different discipline, to communicate. And I thought it was really interesting. I found a study, and I apologize, we'll get the citation. I just sent out with the slides, but there was a good study that looked at hospitalist doctors that take care of children in the hospital. Their contact of a primary care provider after a hospital stay was actually less for children with medical complexity than those without such complexity. And it's interesting how for those people that actually need more communication, that needs more support, that have more complexity in their discharge planning, because of some of these concerns and worries, there's actually less communication that's happening. So just a challenge for all of us to reach out, especially when it's the most difficult to kind of move things forward. Next slide, please. I'll move through this quickly again. What method we use, what tool we use for communication, I think is kind of dictated by is this something that's emergent that has to be dealt with right away, urgent, routine, non-urgent? We use a lot in clinical practice, timeline 0 to 4 hours. Response time needed really needs to be to an 911 or emergency or nurse triage or another immediately available resource. 4 to 24 hours is what we think. I tend to provide my email to all my children with the families of my children with medical complexity, and that's usually what I explain is that I'll respond within 4 to 24 hours, and 24 to 72 hours is usually what we use for a patient portal. Accessibility is one of those things that we need to think about. Is there hearing impairment in a member either with the caregiver or with a child with medical complexity? Is there a language barrier that makes use of a portal pretty difficult, even makes a telephone call a little more challenging? And then the desired task also dictates the method of communication, because when we do something like medication refill, doing it in the portal is much easier than doing an email or phone or things like that. Next slide, please. I'll try to move through this quickly. This again goes back to my experience as a clinician, and I think how things have evolved. And understanding again, like our caregivers, our patients really are our primary resource. But this was a 20-year-old male with Angelman syndrome. Some of his functional abilities include grunting, smiling, and moving to express pain, excitement, and frustration. It is pretty easy for a mother, a primary caregiver, to distinguish pain and excitement. But those are his response to just a breadth of different sensory input. He uses he uses diapers and is fed by a Spanish-speaking mother. he, like a lot of children with complexity, had difficulty during the pandemic and remote education. The support systems that he had by mother's interpretation seemed a lot more limited during the pandemic. But I had recently returned to a in a school program about 6 months before this conversation. So this is someone who has had a number of swallow studies, and his most recent swallow study showed aspiration and not just penetration of thin and thick liquid. So basically, when there was some swallow dye of different consistency, it not just kind of tickled the vocal cords, but there was some evidence that went into the lungs. And again, that poses a risk of inflammatory response and a pneumonia, which can be very, very devastating with complications, including protracted hospitalization, need for mechanical ventilation, tubes and ventilators and things like that, and actual death. It is important to realize that that patient, this child, this young adult, hadn't had an aspiration pneumonia, but mom had noticed, at least over the last year or so, a little bit of a difficulty swallowing. The speech therapist, with what she saw with that swallow study, thought that a feeding tube, a gastronomy tube, was the best move forward, along with the prohibition of liquids and foods and solids by mouth. So when we started to have this conversation with mother, I think she had a lot of concerns. I know I talked to Dr. Goodwin about this, about the real value and connection that mother felt in the experience of feeding. But additionally, mother, and I think rightfully, had a lot of concerns about the tube coming out, being pulled out, how that would affect when it would happen, how it would affect his time at school, which is really an activity that he has enjoyed so deeply and was so well connected to. So next slide. Those are some of the details of the case. So who should be involved in this discussion? We'll do a quick little chat. I think we're running pretty short on time. And Robert put the word cloud link. So people want to put who's involved in this discussion, just click that link out of the chat and put in your response. Parent, okay, good. I think I appreciate that one coming up first. I think the school is critical, especially since I was guiding some of mother's real reservations about the tube. Nurse, absolutely, both kind of clinical team nurses, but if the child had a home nurse, getting engaged is really important. Parent is important, but making sure we have caregivers. School tends to be gaining more and more weight, which I think is important, especially since one of those things that mother called out. So I think social worker, I think there's the mix of those two. I think it's split in towards therapist. I think a lot of the team members that we had listed on the other slides, and very likely some of those that we missed, or I missed, excuse me. I think that, and the reason why I think us as a group thought this would be a important activity is that it is a broad team, and it is certainly not doctor and caregiver and patient. But there's just so many. I see special education within there, which I think again is also critically important. So I think that's a pretty good list. In the interest of time, I think we'll keep on going and we'll send out this word cloud to the rest of the group. And then I'll let people put things in the chat and about how the decision should be made, but I'll turn it over to Nicole for her own lived experience and her kind of insight in being a part of some very difficult decisions.
Sure. I think what I like to let providers know is that the family has a lot to say on overall quality of life and how that matters in the overall decision-making process. I think in our case anyway, a lot of the interventions that my daughter has had, which have been pretty extreme. I mean, she has a GJ tube, a deep brain stimulator, a colostomy bag. Those are really, really big decisions that go beyond just, will this medically help the child, and what does that actually look like in your day-to-day life? How are you going to be using that at home, and to what degree of integrity will you be implementing that tool? Do you feel like you have the resources available to you to follow through on this effectively and keep it functioning and safe? And is it easy for you to get to the hospital in a timely manner if this tube falls out? And what does that look like? How will it be used in the community? Is this going to limit or hinder your ability to get out and do the things you want to do? Or is it actually going to give you more freedom to get out and do those things? But do you just have to kind of revisit what that looks like and what supports you need to make that happen? So quality of life is a huge consideration that we bring to the table, that realistic implementation within the home and community. And also just always bear in mind the family's cultural or socioeconomic status, their familial supports that they have available to them. For instance, in our case, we have both sets of grandparents, siblings nearby, helpers around. And so as we broach these next big things, we are always confident that we have a lot of support to help make those things happen well for us. And to just be mindful of that and to have those conversations with families about what is this really going to look like. And I think there's also sometimes an assumption that even for a well-educated, fairly well-off family making a decision like this, oh, well, they'll be fine. They'll get the training in the hospital. They'll go home and do it. And I can say, like, I have a master's degree. My husband's an attorney. We got home with the G-tube and I had to call a friend and FaceTime her. And I said, I know that they just showed me this, but I have absolutely no idea what I'm doing. I'm panicking. I'm freaking out. And she had to walk me through from Washington, D.C. on FaceTime what to actually do when we got there. And we had all of the resources in the world and the capacity to do it. It's just a lot. So these decisions are not to be made lightly, and they should definitely include a lot of lifestyle factors too.
Yeah, and I can't think that enough. And again, I think that I need to challenge myself and challenge my colleagues again to think about the full breadth of consequences, challenges, implications for those medical decisions that are made. Next slide, please. So this is a quick follow-up in the case. I think we're running a little bit behind. But after bringing in the team to discuss this, speech therapist, Medicaid, caseworker, lead teacher were involved in those discussions. And I think one of those things that were important in this discussion is to understand that a single aspiration event can lead to aspiration pneumonia and aspiration pneumonitis. So inflammation and infection from aspiration can lead to death. Mom ultimately elected against the G-tube placement. In this case, the patient was unable to provide a stent. So when we think about medical decisions for children, there is consent and assent. Consent is making a decision about a particular procedure. Assent is including minors and those that may have more limited capacity to participate in that decision. And unfortunately, this was not a case in which that was a possibility. And as a follow-up, a year later, there was another swallow study. And for reasons that are kind of beyond my explanation, it showed a little bit of penetration, but no aspiration. And mother just reported some overall improvements and a difficulty swallowing and feeding without real issues. So this was just one of many different cases that I think conventional medical wisdom might have conflicted some degree with caregiver and patient needs, and at the end of the day, I can think that the most clear medical answer was not the right one. So I think that's one of those things. I've had lots of experiences like this over my 10 years, and I think again, hopefully. All of us as clinicians can just continue to listen more and engage more in understanding that these more difficult medical decisions are really loaded.
And I wanted to comment really quickly on a comment in the chat about presenting the net positive and negative options and hope that they'll choose what's best for the child. I think what becomes tricky is what's best for the child is so subjective, and a family's version of best could look completely different than a school team's or a clinical team's version of best. I have friends who have had a medical option to place multiple other interventions like a colostomy or a feeding tube or the net, on and on and on, prolonging the inevitable, doing something that they didn't feel was manageable given their circumstances. And from someone else's viewpoint or opinion, that's essentially like letting your child die. To that family, that was honoring their child the best way they knew how, because their child had been through enough and was suffering tremendously, and it was just going to add another layer of complexity and suffering. And so I appreciate the comment, but I also just think it's really nuanced, and to just be cognizant that best looks really different, and best can also change over the course of a child's life or a family's experience along their journey.
That's so well said, Nicole. Yeah, so using shared decision making often is when there are options, and sometimes there is a conflict, right? That those crucial conversations at what is the right or best is actually what everyone comes to a shared decision on, and everybody brings again all of those values and experiences to the conversation. And so I just think that that you said it so well, Nicole. So thank you.
And just cover our key takeaways really quick. So, high stakes, strong emotions, and potentially challenging and opposing opinions can make communication challenging, and shared decision making is an interactive collaboration process where all parties participate and together arrive at a treatment plan. And these are some of the components of communication to keep in mind, such as what we say, the words we use, how to say it, delivery method, listening, humble inquiry, and responding. Next slide. And I will pass this over to Christy to wrap up and end our echo today.
Thank you so much. Thank you, presenters, and Tara, for sharing your case. We learned so much today. Thank you for everyone who joined us today. We really enjoyed learning with you. This is our last session. So just a couple of wrap-up items for you. We have a short survey. It should be in your inbox now, and we really appreciate you taking it. It should be 3 minutes or less. I think there's maybe 14 questions on there or something. They're all multiple choice. We really do use your feedback. We hope we use it to improve our echoes. We use it to plan future trainings. So we'd love to hear from you. The resources, we will be sending the slides and materials to your email just as soon as we can get them processed here. And then a certificate of attendance will be sent to your email as well for the sessions that you attended. Stay in touch, and we'd love to hear from everybody. Thanks for joining us today, and we'll let you know about future trainings. Thanks, everyone.